absolutely delighted to have Shahzadi talking to us tonight, because when we did our Know Your Menopause survey, the subject that, not the survey, but the poll, the subject that came up that the majority of people asked for was to do with mental health and menopause. And it's such a big thing. And we know that with COVID, the last 6 months and the coming 6 months, maybe that mental health could be challenged even more. And Shahzadi, I've got a list of what she's done here and the training that she's got. And all I can tell you is, because I could be here half an hour reading this out, is that she is so well versed in all things ladies' health and menopause. And we're delighted that she's here tonight to talk to us. So, Shahzadi, thank you so much. And I mentioned that the main reason that we wanted to cover mental health and menopause was because that's what most people told us that they wanted to actually have covered. And so many women don't know what's going on with their body and mind as they start to go through the menopause. And I know that for me, it was the unexpected panic attacks that I'd never had before in my life. It was the just dreadful mood swings that uncontrollable mood swings that affected me, that was so challenging, not just for me, but for my family as well. And I had absolutely no idea what was actually going on. So can you just explain to us what the common symptoms of menopause are? I had no idea that was a symptom. What the common symptoms of menopause are, and when people can actually expect those could happen on that menopause journey?
Yes, of course, Claire. So hello everybody, lovely to meet you all, and thank you for inviting me. And I think this is a really good topic to cover, because I think that when it comes to menopause, and when I use that term menopause, I'm using it as an umbrella term to cover both perimenopause and menopause. I think everybody sort of knows about hot sweats or, hot flushes. Also, people talk about sort of moody, irritable, sort of bitchy women, but actually I think they don't quite understand how these sort of mental health symptoms impact and affect women. And I think on the whole, women don't understand. I mean, I, in my sort of medical journey, have spent about 3 years doing psychiatry. But, in that time, really things like menopause didn't come up in the sense of working out whether or not that could be some of the reasons for some people's symptoms. But the menopause journey for a lot of women, although the average age of menopause when their periods stop is 51, the symptoms do tend to start quite a bit earlier. And if you are a woman who in the past has suffered with PMS, premenstrual stress, PMT, or if you've suffered with postnatal depression, or if you've had bouts of depression before in the past, then you are a slightly more vulnerable woman in this age, in this sort of journey. And the symptoms that women tend to get are, we hear nowadays more about anxiety, low mood, but really it's more about a lackluster, feeling easily overwhelmed, hard to make decisions, not being able to cope so well, and finding that they are more sensitive, finding themselves more irritable. I had one woman say to me today, I knew something wasn't up because I've got a puppy and I would get these bouts of rage and I'd want to kill the puppy. And she said, that's not me. So our hormones have a huge part to play in the way that we feel and how we can sometimes feel out of control. I also think at this time and in our lives, there is so much going on for a lot of women in respect of their own personal journeys, careers, motherhood, children leaving home, relationships, that unlike maybe when you were in your 20s, when there really was only you to consider, it's a very multifaceted sort of existence at this point, where often women are put themselves as a much lower priority, and so don't understand that some of these symptoms that they're experiencing are due to their hormones. It's not just aging, it's not just growing older and everything else that they're having to put up with. So I think that these are more debilitating symptoms often from those tangible physical ones that a lot of women experience, like the hot flushes or the night sweats, because those you can see, you can, they're obvious. Whereas what's going on, this internal turmoil, this sadness, this lack of motivation, this feeling not worthy, loss of confidence, along with some of the other symptoms like forgetfulness, memory lapses, which then chip away at your own self-esteem and confidence, have a huge part bearing to play. And this is very different from clinical depression. This is menopausal mood disorder, which is a genuine disorder. But on the whole, for most women, symptoms tend to fluctuate because it is about, again, going back to hormones, it's about the hormonal levels fluctuating, compared to clinical depression, where it seems to be more of a sort of sustained, constant sadness and low mood. And these are two different things, depression, clinical depression, and menopausal mood disorder. But mental health, mental well-being, the impact is huge. And I would go as far as to say it's much more so than those physical symptoms that women experience in menopause.
Yeah. So when women come to see you, what's the symptom that they first come to talk to you about? Is it the physical symptoms, or is it the mental emotional symptoms that they come to you and say that they're struggling with?
I would say more so it's more the mental and emotional symptoms, because those are the ones that stop them functioning. Those are the ones that stop them doing their jobs. They're the ones that are impacting on their relationship, their day-to-day, that they're just feeling glum, they're feeling sad. Often they will say things like, I don't really even know why I'm feeling like this. I've got a nice job, or I've got a nice partner. I don't have financial woes. I don't really know why I should be feeling like this. But I just don't, I've lost that sort of, I often say that sort of joie de vivre, or they've lost that shine and that sparkle. And that's the thing that tends to be more so, along with sort of the hazy, foggy brain, and they're starting to doubt themselves. They're starting to feel not themselves, but it's not because of the vasomotor symptoms like the hot sweats and the night sweats. Yes, they're there, but often that's not the driving force or the tipping point, unless they tend to be, sort of really frequent hot flushes and night sweats. But insomnia is a big part. So insomnia is one of the things that often will drive people through the door too.
Yeah. And just out of interest, I mean, just in my own personal story, I didn't know what was going on for like 7 years. And nor did the doctors I spoke to. But it's, it's like when you get to the tipping point that you just wish and hope that somebody will actually listen to you. And when you lose it in the doctor's surgery and you think they've got to take notice of me, got to take notice of me now. If I'd known more at that time, I would perhaps have gone more forcefully to see my doctor. And if I'd known more about the menopause and things, I could perhaps have gone earlier and got satisfaction, I think. So where on that journey of women feeling these mental and emotional struggles, where on that journey should they come to see a doctor? Near the beginning or towards the end?
Oh, definitely near the beginning.
Cope, I mean.
Oh, no. I mean, the coping thing. And I think, just to sort of touch on this, women who have generally been really good copers, who've not even suffered anxiety before in the past, they also experience these symptoms at this point. Suddenly they're thinking, we can't cope, or they find it so hard to make a decision. They feel so easily overwhelmed. And I would say go sooner rather than later, before everything crumbles and sort of collapses. And even just talking to somebody, even if your GP doesn't know a lot about menopause, talking to somebody, helping to sort of voice those things that are going on, but also being able to share, can sometimes be very helpful. there are, it doesn't always have to go down the hormonal route of treatment. Sometimes initially, if you get support, it may be that you can have some talking therapy, or you have some CBT. Often, unfortunately, I do hear women tell me that they've been offered antidepressants, and I think that's where the concern is, that really this is not clinical depression. This is more hormonally driven, and so antidepressants should not be offered first line. The NICE guidelines very much clearly state that antidepressants should not be offered first line, and we should be considering hormone treatment for those women that can take it.
Again, in the survey we did, 1 in 4 women were offered antidepressants, and we wonder, we don't know for sure, but we do wonder if that's because they perhaps weren't talking to the right doctor in their surgery who understood more about menopause, or was interested in women's health, for example. So, what would be a good question for women to ask when they phoned their surgery, to ask for the right, to be put in contact with the right person?
I mean, I think it would be a good question to ask would be to ask if there is anybody in their practice who does have an interest in menopause or women's health. Often nowadays in practices, you have GPs who do have their special interests. I was in a practice where my special interest was menopause. Another doctor's was sort of musculoskeletal injuries. And so, everybody has their own special interest on the whole. So, and I think if you don't find joy from the first doctor that you go and see, maybe go and see another one. But I think often women leave it to a point that they are so in need of help that, being offered antidepressants, they often will take it and walk away with it because they feel that they can't ask anymore, or they don't know what to ask for. But I've often had women say to me, look, I know it's not like depression. I've taken the antidepressants, they've not worked for me, because it's not depression as such, it's very different. And especially if some women in the past have had depression and they know that this feels very different to that. But, again, if you are somebody who's prone to PMS, who's had depression in the past, or who has had postnatal depression, then you very much more are at a higher risk category for developing something like this. Yes.
Absolutely. So what would your advice be to a woman, apart from finding out in the surgery who is the best person to talk to? What would you encourage women to do some research beforehand?
I think it's always good. I mean, for me, I always think about healthcare as a shared responsibility. And I think if you can get some information beforehand, if you can find out or download one of those menopause symptom checkers and tick off the boxes and take them to your GP, that can be really helpful. I think that from the point of view for a lot of women is, again, I'd reiterate, go sooner rather than later, but and go prepared if you can. But often, I think when you are in that sort of sad or flat state, it can be quite hard to, to find or gather information. And sometimes, all that energy is used in just making that appointment, going to the GP. And then sometimes, one of the things that you can be quite disappointed walking away. But I would say don't give up, really, do just go and find another doctor or find another doctor that can and will listen and does have a better understanding.
Yeah, but I know also sometimes when you are in that state, that actually finding the words to communicate effectively is also difficult, isn't it?
Well, just finding words. I mean, for some women, word finding difficult is a real common thing. And they said that, they just felt that there were gaps in their conversation, or just making conversation can be hard work, or feel that they can feel quite depleted at the end of it. So it is a very challenging time for a lot of women, and mental health, well-being. As you said, Claire, it's doesn't just affect you. It has that effect on the people around you, your work, your family, your partners. So it has a much bigger reach and bearing than just you as a person. And we know that, you know, suicide rates are the highest in the 45 to 54-year-old age range. Depression is highest in that age range for women. So it is a very vulnerable age for a lot of women.
Yeah, I understand also that divorce is highest in that age range. I wonder why.
Yes, exactly.
So what would be, you mentioned antidepressants and HRT, what other that you can help them with? What can women do to help themselves?
So, I mean, I often talk about things like exercise, releasing endorphins. And if you can just get over that hump of sort of lack of motivation or feeling that, oh, it just feels like too much hard work, then if you can do some exercise, that really does help to boost your endorphin levels, your serotonin levels, your noradrenaline levels, dopamine levels. And the effect doesn't just last for the length of time that you do an exercise, it lasts for hours afterwards. Yeah, I mean, I also find it really hard to exercise. And I always tell myself, so if ever I go on my cross trainer, I get to about 3 or 4 minutes, think, I don't want to do this, I don't want to do this. But now, having done it enough times, I tell myself, just get to that 10-minute mark, just get to that 10-minute mark, and then you'll feel better. And actually, you know, knowing that about myself, I know once I get to that 10-minute mark, I can do another 10 minutes. But it's that first sort of 5 or 10 minutes, which, you know, I often want to just step off and not do anything else. And I think if you can do some exercise, that's really good. If you can eat well, you know, not just reach for sort of refined sugars and carbohydrates because you think, oh, I need that bit of energy, or I need that little bit of a kickstart. If you can have a varied diet, lots of fruit, vegetables, and also I think, you know, for women, in the sense of things like chickpeas, hummus, lentils, these have got sort of natural sort of isoflavones in, so phytoestrogens, which can help a little bit, sort of give you that bit of boost and fill you up without it giving you that sort of sugar high and spike. Those are really good things. I mean, I touched on talking therapy, you know, sharing with your partner, talking to your partner, talking to, you know, some friends, letting them know how you feel. And sometimes it can be easier for women to talk to other women because it can be that, you know, talking to their partners can be a bit frustrating, or that actually anger can be a bigger symptom. And just to put into context, anger is also a way of expressing low mood. Anger doesn't always have, you know, anger is one way that a lot of people express their low mood. I often say it's more of a motivational emotion, because anger gets you to get up and do things, whereas when you feel sad, you end up just more or less sitting still and not doing as much. So at least anger is a more of a productive emotion, but it can also be destructive as well. So talking to people around you, and doing things like that you enjoy, making some time for yourself to do things that you enjoy, whether it's things like knitting, walking, and the other thing is, when you've got a list of tasks, or if you've got a long list of things to do, I often say break it down into small lists. And one of the things I say is almost think about it as an in tray and out tray. You've got your big list, maybe just move 2 or 3 items into your in tray, do those, then you move them into the out tray, then move another 3 or 4 in there, then do the same thing. And by breaking things down, it can seem less overwhelming. And it's also quite nice to see yourself being so productive as well, to sort of see an in and an out tray. So I think you need to sort of just reach out for some different skills in the sense of how you're going to manage and cope during this time.
Absolutely, some really great advice there. So if I was going to ask you for your top 3 tips to give all these lovely ladies here tonight to take away, what would those top 3 tips be?
I mean, I was going to say, well, one I was going to say is don't be too hard on yourself and break things down. You don't have to do everything in one go, and you don't have to do, you know, a 26-mile marathon or something. So if you just break things down into small segments, achievable segments, then do that. If 10 minutes, you can do 10 minutes of exercise. do 10 minutes of exercise. If you can do 3 tasks rather than 20, then just do 3. So break things down into much more achievable segments. Also, you know, go and see somebody sooner rather than later. If you are starting to feel not like yourself, then, you know, don't sit and wait until you turn into this sort of monster of a person and everything around you falls apart. And if you can't find, if the first GP or the first doctor that you see can't or won't listen or doesn't understand, then don't give up, and then just go to another one and another one and another one. And I think those would be my sort of top tips, is not to give up, you know, break things down into achievable chunks, and do a little bit of exercise, actually, you know, to do things that you can manage, rather than giving yourself a long list of tasks and challenges, which then you feel overwhelmed. Oh, and another thing is, don't make big decisions. You mentioned divorce and relationship breakdowns. I often say, don't make big decisions in this time. Wait until things are much calmer and stable before you make that big decision.
Some great tips there, particularly the last one, I think, can be can help save even more stress, which can lead to even more. And what I loved about those tips also is that each one of them is an element of giving back control to the woman, because it's so easy when you're in that mental emotional state to feel that you're losing control, and that you're giving your power away to a GP or to somebody else. But each of those tips was, from my perspective, were really great, because it just gave that element of control. Thank you so much. That was absolutely fantastic. And thank you again for joining us. And I just wonder if, we've got some chats coming up now. So I'll hand on back to Elizabeth, who is chat monitor this evening.
Yeah. If anybody has got any questions, pile them into the chat and I'll sort them out for you. I have a question about CBT. How effective can CBT be in helping menopausal depression and anxiety?
Well, we know that CBT is equal to an antidepressant, you know, when it comes to being as effective. So about 30 to 40%. Okay. So, but the thing is, it can sometimes take a little bit longer to achieve that. So when it comes to sort of regular depression, often both things are started at the same time, because then at least they can overlap. But we know that in menopause, that it can be really helpful for women. From a point of view stats, it's about a similar statistics, but I don't really know from a timescale point of view. And it really depends on whether or not you can stick to it and you can do it. And I find that a lot of the time with women, that it's quite hard for them, because if you're not sleeping so well, if you're feeling tired, then actually to remain focused and concentrated, it's not that you're lazy and you don't want to do it. Sometimes it just seems a bit too much effort, and it can feel a bit uphill. So often, you know, going on to something like hormone treatment, I find gives you that little bit of oomph, or a little bit of get up and go, for you then to get that ball and keep it rolling. And that's often what I find.
Because I had CBT in the past and it was great, but you had that huge long waiting list to get there.
Exactly, yeah.
And then it was a 10-week course, so it took a while. But I have seen a lot of doctors ask her to go in as well. Yeah, thank you. We have a question from Joy. Joy, would you like to unmute yourself and ask your question?
Oh, sorry, I had to try and find the unmute button. Now I've got to remember exactly how I asked it. Thank you for a start. I nearly cried when you described some of those symptoms, because that's been my last 2 weeks plus. I'm just thinking, if I were to be offered a HRT type treatment by my GP, what are the positives or negatives with patches and tablets, and how rapidly would you expect to see a positive result if that was what was going to help me? Does that make sense?
Yeah, so the reason why women feel the way they do during this time is because when estrogen levels are low, it causes the breakdown of our happy neurotransmitters much faster. So in a funny way, estrogen acts like an antidepressant, like an SSRI, by keeping our serotonin levels high. So when you are, so you asked the question about almost like which type of HRT. Often it's difficult to say because it's individual, but I do tend to go for more, personally I tend to prescribe more the ones which are through the skin, the transdermals, the patches or the gels. And on the whole, when you start an HRT, it takes about at least 2 weeks for it to kick in, you know, and for you to start to notice a difference. And about 4 weeks, you notice more of a difference, you know, not maximal, but, you know, you notice more changes. I say that, you know, in a very broad way. I will often find that women say to me within days, you know, that they're sleeping better or they're noticing changes. And when you sleep better, then actually your mood feels much better the next day. So 2 weeks, I'm being cautious and I'm saying it's about 2 weeks for you to notice a difference. And by 4 weeks, you should notice more of a difference. You know, it should really be settling into your system. But when it comes to which one, I do tend to prefer the gels and the patches because they have slightly lower risks, and particularly if you are somebody who maybe is a smoker, who's overweight, then, you know, I do prefer those. But there are some good orals out there as well that, you know, some women find it easier to keep something like that in their handbag. So it is about individual choice, and it's also about giving you the options and explaining to you, you know, which one might work best for you or which one you would prefer, because there's no point giving you an HRT if you're not going to take it every single day, or if you're going to take one here or miss out a few days here. Compliance, adherence, sticking to it, getting that sort of regular sort of hormone treatment, it works much better to maintain the levels. So yeah. So in a nutshell, that was a lot of answer to when I could have just said I prefer the gels and the patches.
That's great. Thank you. That's really helpful.
I think everybody's been having a bad couple of weeks as well, Joy. You're not alone. I know my mental health has been completely up and down the last few weeks. So thank you for asking.
I think you made a really good point, Liz. Sorry, I was going to say, Liz, you made a really good point about COVID. And I think, you know, again, in the last few days, that's really rocked a lot of people that, you know, here we go into a second lockdown. What does it mean? When are we going to come out of it? And I found this very much so when we first went into lockdown, that a lot of women who were stable on their treatment, it was like a couple of steps back. There was all this wobble. Nobody really knew what was going on. And then things plateaued. And then again, the sort of anxiety, feeling overwhelmed, all of these symptoms seem to come back again when lockdown was being lifted. And I think we're back to you know, some more of this all over again, because we don't know, and uncertainty really does provoke anxiety.
So true. I got to see my mum for the first time since March. She lives up in Newcastle and I had to travel. And yeah, so I had all of the happiness of that. And then COVID came again.
Yeah.
On top of a huge progesterone strike for me. So yeah, it's not been an easy time for a lot of us, definitely. Tina has a question about HRT, which I really like.
Hello there. Thank you for all the chat so far. It's really interesting and it's lovely to see you all. I first went to my GP because I was suffering from hormonal rages. I had no idea that I was perimenopausal and was really totally shocked when my GP said, I think you need HRT. I had a period of HRT, things stabilised off, I was on for about 18 months, came off it. But I am noticing that the hormonal rages and mood are returning. And my question really is, should I go back to my GP and ask to go back on HRT?
Hi, Tina. Yes. I mean, first of all, I'm not sure why you came off after 18 months, because if you're perimenopausal, then that journey is going to take some time. And I usually say, let's just taper somebody down if we come into a point that we're thinking about it, unless there were some medical issues, you know, unless there was a medical problem, or you know, something came up. So often most people's symptoms won't go away just up with 18 months of HRT. And it sounds very much that, you know, you're going back to, I'm not going to say back to square one, but, you know, those symptoms are very much sort of to me signifying that you still have got those hormonal changes going on, fluctuations. And good on your GP in the first place getting it right, but taking you off after 18 months, or unless it was, you know, your choice, or there was a different reason for it, I wouldn't be doing that at this point in time. Yeah.
Yes, thank you.
Barbara also has a question about HRT, which I am really, really interested in the answer to this one as well. So Barbara, are you there?
Yeah, I'm here. Thanks, Liz. Hi, Dr. Harper. Hello, ladies.
Hi.
For me, I've been on HRT. I had a surgical menopause. I've been on HRT for a year. Actually, it's the anniversary of my hysterectomy, and my ovary's being removed today, so it's a year on. So I've been on HRT, and I felt that actually, you know, everything's been really, really good. I felt HRT for me was a real game changer. It's been absolutely fantastic. But I've noticed slowly over the last couple of months that very, very slowly, and it's crept up on me, but now it's at a point where I think I might need to do something about it. My anxiety, which was my worst symptom after my surgery, my anxiety is really coming back, and it's quite bad at the minute. So I just wondered, you know, once you're on HRT and everything seems to be fine, what happened? How do you know if it's your HRT not working anymore, or do I need levels checked, or what should I do?
So one of the things, Barbara, is often it may well be that you need some more HRT. You probably do need your levels checked. You probably need maybe a change in your dose, an increase in your dose. The other thing I just need to say is, when you got sort of menopause or low mood, you can still feel, you know, anxiety and depression on top of it. You know, if you think back to your premenopausal self, when your ovaries were producing their own hormones, that didn't stop you from feeling sad or low at times. It didn't stop you from grieving. It didn't stop you from getting anxious before a big meeting, or, you know, before an event or something like that. So those kind of things can still happen when you're on HRT. But, you know, one of the things is, I would be thinking that from how you've described in this short space of time, the fact that, you know, you've gone through a surgical menopause and you're finding that your symptoms are recurring, to me it sounds more like it is due to the fact that your HRT dosage needs to be re-looked at and reviewed. And the other thing, just to throw in the mix there, is I wonder if you're on some testosterone.
On just the estrogen. I'm on estrogel, so just the gel, estrogen only.
Okay. I'm a great advocate. I think that, you know, often that women who've gone through surgical menopause can really benefit from some testosterone. But, you know, it's on an individual basis. But on the whole, I do think that they can do. So yeah.
How do we persuade our GP to give us testosterone? Because mine told me it was a left field idea by you specialists.
Okay, well, it's not, because it's in the NICE guidelines for a start. So it's not something that, we menopause doctors have made up ourselves. I think it's, you know, I often defend GPs and I say it's really quite hard for them, because as a generalist, and having come from that background myself, it's very hard to be a master of everything, and when you've only got 10 minutes. And testosterone, whilst the NICE guidelines have got them in the NICE guidelines, there is no licensed female form of testosterone on the NHS. So what that means is, every time a GP is prescribing it, they're prescribing it off license. So they themselves are taking on board a bit of risk, effectively. And if it's not something that you feel particularly comfortable about or know much about, then it is a difficult thing to get your GP to prescribe that. And so if they can't, then maybe the thing to do is get yourself referred to an NHS menopause clinic, and that is an option. Or obviously the other alternative is to go private. But, you know, if that's not an option, then there are NHS menopause clinics that your GP can prescribe. It may take a little bit longer, but actually, you know, it is probably the hormone that can wait a little bit to be added in, because it works best when you've got enough estrogen, you know, when you've got estrogen in your body, so it doesn't have to be started at the same time as everything else. So even if it takes, you know, a couple of months for you to be referred and be seen, that it can be, it's not the end of the world.
Does that answer your question, Barbara?
Yeah, that's great. Thank you. I think I will try and call the GP. I think I've been reluctant to call as well because I didn't want to bother them during COVID and stuff. You feel like you don't want to bother them with something at the moment because everyone's, you know, obviously trying not to go into their doctor's surgeries and stuff. So, but I think.
Well, Barbara, I'm going to say to you, look, I think that is so typical of all women saying that, you know, we don't want to bother, you know, we're not a priority, but, you know, menopause impacts our coping mechanism, our day-to-day life, and it affects all the people around us. So it's actually a really important thing to get on top of. And I've been doing Zoom consultations or video consultations with my patients, which have worked amazingly well, much better than I actually thought that they were going to in some ways, and the way they've taken off. But even if your GP is doing telephone consultations, there's been guidelines from the British Menopause Society on how you can do menopause consultations by phone or by video. And you know, one of the things that we're worried about from the GP world is that patients aren't coming to us and things are being missed or left and get to a point that they then become harder to manage. So I'm going to say to you, don't worry about bothering your GP. Having worked in NHS for 26 years now, I've seen, I can say to you, this is not one of the things I would be saying to people not to bother me about. There are plenty other things that I could say to people, don't bother me about, having seen what comes in through the door. But this is definitely something I would say, you know, get it sorted, especially if that anxiety is starting to build up. It could potentially just get worse.
Thank you.
I think that's advice we all need to hear. I mean, as you said, women are so bad just going to the GP anyway about themselves. So yeah, especially in COVID, we need to be reminded that this is something that we can get sorted and we can get help from, and it's important as well.
Yeah,
definitely. We have Heather. Heather, are you able to unmute yourself with your question?
Hello, there we go. Yeah, I think you've got me. Is that right? I know you can't see me.
We can hear you, thank you.
Yeah, okay. Yeah, I went through the menopause some time back, and I've been on and then off HRT because I developed 2 breast cancers. So going back onto HRT is a no-go.
Barbara, there are other pharmacological treatments that women can take for menopause symptoms, and funnily enough, one of the things are antidepressants. They work well for hot flushes, anxiety and sleep. Also, there are other things that we can take for you know, hot flushes, like clonidine. So there are other pharmacological but non-hormone treatments that women who've had breast cancer can take to help support them through this time period too.
Wonderful. I'm taking antidepressants anyway.
Okay.
And I did try some other medication, which was supposed to be very good for hot flushes, but I think that was a particular type of antidepressant, but it's not been a big help. So,
okay.
Yeah, so clonidine I'll go for. Speak to my GP. Thank you very much.
No problem.
I think that's another important point as well, that antidepressants can also help with some of the other symptoms as well.
Yeah, yeah.
Because a lot of us think, oh no, it has to be HRT, but actually, I mean, I take tablets for Parkinson's disease, for restless leg syndromes, and a very small dose because they help. So sometimes we have to accept that other medications can give us the help we need.
Yeah, and I think it's really important, you know, Barbara's point, because often when it comes to menopause, people talk a lot about HRT, but you know, menopause affects all women, and sometimes women with breast cancer feel a bit left out and think, well, what's there for us? And I think
we do.
And I think it's important to sort of add in those sort of other pharmacological treatments that are available out there, you know, and things like for libido, sex drive, vaginal dryness, all of those kind of things, which help women feel like women and feel feminine, alongside the the hot flushes, the mood and the anxiety. So I think it's important to address all forms of treatment really for everybody.
And we have, it's not a question, but Helen had a great comment where she just says she had no idea that menopause and perimenopause can cause brain fog and affect your mood so much. And we need so much more knowledge out there, which is what Pausitivity is all about, is trying to spread the knowledge. So again, thank you again for sharing yours with us tonight.
One of the things that you all might find quite helpful is that my Facebook page is on Tuesdays at 10 o'clock. I do a menopause coffee clinic where, you know, some of these questions that you've asked, I will then answer them for you. And often I'll have a theme running through per week, just so that we've got some kind of structure. So that would be really, if you've got questions, then do join me over on my Facebook page, which is at the Harper Clinic LDN, and I can answer some more of your questions next Tuesday for you.
Well, thank you. That was really, really interesting. Thank you, Dr. Harper.
Thank you.